Morning, everybody. Thank you, Bombay guys, for arranging this nice symposium. So I'm going to share my experience of using stents in below-knee arteries. I have no disclosures. When we look at critical limb ischemia, it's a multi-vessel, multi-level disease with challenging lesions, especially in diabetes and renal failure. And if untreated, almost 50% are major amputations, causing increased morbidity and mortality. Endovascular revascularization reduces morbidity and mortality as compared to bypass. And BTK disease revascularization needs better patencies if there is a large tissue loss. Stents do play some role to achieve this in below the knee lesion. If you look at the anatomy here, BTK arteries, they are frequently involved in CLI patients, especially in diabetics. So far, it has been a no-touch area for endovascular treatment, but it's because of small vessels, long lesions, and calcifications. But there are tremendous improvements in hardwares made in recent years, like dedicated guide wires, balloons, and dedicated stents as well. And we heard Venkatesh about using bioabsorbable resorbable scaffolds. So there are multiple varieties of BTK lesions. Many could be 50% long occlusions, more than 10 centimeter. They are severely calcified and undilatable lesions. And there are different stents, which could be like balloon expandable or self-expandable. And when we look at this, I'm sure all of us have seen this diffuse disease in the tibial arteries. It's very rarely you would see a very isolated stenotic lesion in just a single tibial artery, and that's extremely rare to see. Especially if they're short lesions, whether the angioplasty or stenting, that's a question. And if there are ostial lesions involving tibials, whether to do only angioplasty or whether they need a kind of kissing stents. And if long lesions, what do we do? So these are some of the examples of self-expanding stents which we do not have these from biotraining. So when we look at BTK stenting, generally it's considered as off-label use, and it's a bailout technique for flow-limiting dissections when after the angioplasty, or if there's a restenosis or recoil after balloon, uh, or if there's suboptimal angioplasty or atherectomy results, then one could think of doing as localized below the restenting. There is a significant data that BTK stenting is effective and durable primary endovascular strategy for CLI patients, which could be either a balloon expandable or self-expandable. And what are the tips and tricks? Obviously, we have to consider stenting from healthy to healthy vessel. When we are using drug-eluting stents in bifurcated lesions, always use it as a kissing stent, otherwise there can be atheromatous plaque shift to the other artery. It's like when we do a common iliac, the similar kind of strategy used here. Better to use one long than overlap, and if there is overlap, use it should be at least centimeter. For balloon expandable stents, dilate to 1 to 1 to 1 ratio. And for self-expanding stents, one size larger than the vessel diameter should be considered, and post-dilatation with balloon half size should be larger than the stent. So these are some of the practical tips. Should be adequate distal runoff below the ankle and foot, because if there is no runoff going into the ankle and foot, then probably no matter what you do, it's going to close up. Vessel caliber should be at least 2 millimeter, and that is why stenting, especially in the lower third tibials or going into the foot, is kind of not desirable. Stented vessel should be dominant vessel feeding the foot or feeding the non-healing ulcer, and that's important thing we have to look at. When we prepare the vessel, it should be an adequate angioplasty or atherectomy. Sometimes we use nitroglycerin, giving locally in the tibial vessels 300 to 500 micrograms, and stent 3 centimeter above the ankle should be at least placed. Anything beyond that, one should not consider stenting, and also avoid across the big branch. If vessel size is less than 2 millimeter or poor distal input, don't think about stenting. So it's my experience at one center, retrospective study, observational. All patients who required BTK stents in last 4 years we included. There were 25 patients, 28 limbs, and primary findings were limb salvage, and secondary findings were amputations, wound healing, and reinterventions. Common hardware which used is 0.014 and 0.018 wire, and stents were either balloon expandable, which were mainly coronary drug-eluting stents, and 2 or 3 patients were used part of the Merrill trial, which we used bioabsorbable scaffolds with a diameter range of 3, 3.4, and 4 mm. And these were the length from 28 to 48 mm. And balloon size generally would be 2.5 going up to 4. Just an example of TP trunk occlusion with a good runoff and putting a drug-eluting stent in the TP trunk, and nice results. These were the results. So commonly around 66 was the mean age. Again, more in males, we saw only 4 females. Majority had diabetes and hypertension. 12 patients had ischemic heart disease, and excuse me, 4 had CKD disease. Commonly, what we saw was more on the right side of the body, and 8 left legs were injured, and 3 in bilateral limbs. The disease overlap and disease pathology: 13 had SFA stenosis, 14 had popliteal stenosis, 23 had TP trunk stenosis, and 19 had TBL. So it's an overlap of all these anatomical lesions. They all had drug-eluting stents. 20 patients had everolimus. No, I have, thanks. 20 patients had everolimus drug-eluting stent, which is almost 70% majorly. 2 had sirolimus stents, and 2 had zotralimus. All were coronary stents, drug-eluting stents which were used. And the best advantage over a period of time, what we realized, because the cost-wise, since the coronary stent prices came down, it was fairly fitting it into all the outcomes and budgetings. 17 had gangrene of the toes, and 11 had non-healing ulcers. 7 patients out of these did not require any amputations. 20 had minor amputations, and 1 had a major amputation of all 28 limbs. If we look at the post-operative wound status, 23 had healed completely, 5 did not heal, and 27 patients we achieved the limb salvage. 1 patient had to undergo amputation. Out of, when we consider mortality, 17 patients survived, and 8 were died because of all-cause mortality. Now, this is the incidence of amputations according to type of drugs. So, 4 patients did not have any drugs, and out of those, 4 had minor amputations, no major amputations. The one who had everolimus drugs, 6 patients did not require any amputations. 14 had a minor amputations. None had a major amputation. When we use sirolimus stents, 1 did not require any amputations. Nobody required minor or required amputations, but 1 had a major amputation. And zotralimus, none had amputation. 2 had a minor amputations, none again in major. So of all 4 cases with drug-free stents, all had minor amputations. And 20 with everolimus, almost 30% required no amputations, and 70% had minor amputations. When we look at the incidence of limb salvage as per the type of drug which was used, again, those who did not have drugs, all 4 we could salvage the limbs. Everolimus, 20 patients were used, and all 100% had a limb salvage. Sirolimus, 50%, because there were only 2 patients we used that, and zotralimus, 2 patients all were salvaged. These were the segments which we stented, BTK. Popliteal, distal popliteal had 5 patients. Out of that, 1 did not require amputation, 4 had minor amputations. All 5 had a limb salvage. When we stented the TP trunk, out of 21, which is most common segment to be stented, 5 did not require any amputations, 15 had a minor, and 1 had a major amputation. So almost 20 had a limb salvage. And when we used stents in 2 patients in anti-tibial artery proximal, 1 did not have an amputation and 1 minor amputation. Now the 6 patients required re-interventions from all these 28 limbs. And very interestingly, the observations were that many of all the 6 had a SFA stenting and drug-eluting stents, BTK in TP trunk. And the observations, which I will show you a couple of examples later towards the end, that all the BTK stents were patent in all re-interventions which was seen, but the occlusions were proximal SFA stents in all 6 re-interventions. Out of these re-interventions, 1 patient we did SFA popliteal drug-coated balloon, 1 we did a distal bypass, 3 patients we did mechanical thrombosuctions, and 1 patient we did mechanical thrombosuction and SFA stenting again. Now 4 patients out of 28 required re-interventions. 2 of them had a severe ischemic heart disease with LV ejection fraction less than 30% and had a myocardial events, peri-procedure, probably that's the reason the EF dropped further and had occlusion. All-cause mortality after re-intervention was in 1 patient and all had TPT drug-eluting stents. Those who had patency was noted at all 6 re-interventions. So primary patency 28%, secondary patency 21%. Duration less than a year, 14% had a patency less than a year, 85% had a more than a year. The duration of wound healing, those who didn't have any drugs, out of 5, 18% almost percent wound healing, less than a month, 7.1%, which were 2 number of patients. 1 to 3 months, 7 patients, 25%, 3 months, 14 cases, and 50%. When we look at angiosome related or directed revascularization, 22 patients had direct revascularization, out of which 21 could be salvaged, and indirect revascularization, 6 patients, all 6 were limb salvage. So limb salvage was achieved in 27 limbs, whereas 1 limb required major amputation. Postoperatively wounds were healed in 23 patients. In 5 patients, wound healing was not achieved. There was associated mortality in these 5 patients because of mortality unrelated to primary procedure. All-cause mortality was almost 30% in 8 patients. 4 patients required re-intervention, but the culprit lesions were, 6 patients were required re-intervention. Culprit lesions for re-intervention was in SFA in all of them. We could just compare our findings to Paradise and Basil 2. So I'm just going to go through these quickly. So our study, amputation, major amputation, only 1. 8%, 8 patients had all-cause mortality. 21 patients had a complete healing and relief of rest pain in 26 out of 28 patients. 35%, almost 1/3, had a repeat angiographic evaluation following the interventions. And when we compared with Basil trial, 6% was ours as compared to 15.9 in Paradise. And compared with the Basil surgical arm, 6% versus 13.9%. And so cumulative limb salvage almost 87%. It's a single center, single surgeon study, so limitations being a retrospective, recall bias could be considered. Our study findings match with the meta-analysis done by Sarvas, Nikiforos. The level 1A supports the use of infrapopliteal drug-eluting stents for short to medium length lesions. Wound healing in critical limb ischemia requires long-term patency that can be achieved with drug-eluting stents. So there are few trials, Dr. Venkatesh also showed earlier, Paradise, then Many studies, meta-analysis have showed drug-eluting stents better than others. This is another meta-analysis. Look at the outcomes, primary and secondary pregnancies. In all patients with infrapopliteal occlusive disease, drug-eluting stents result in improved one-year patency and freedom from TVR, but not better survival or limb salvage compared with bare metal stents. It's another long DES BTK study published in Jan 2020 through Link. 10 years data used Giants everolimus and amputation-free survival in Rutherford category 4, 5, 6 was almost 70% at 1 year. And for 4 and 5, over 90% amputation-free survival. For category 6, 50% only. This was from Raymond Warko, Angiology 2019, Systematic Review and Meta-Analysis, and use of drug-eluting stents in BTK arteries. It significantly improved primary patency, freedom from reinterventions, freedom from major amputations compared to BMS or drug-coated balloons, and sirolimus coating was better than paclitaxel coating. This is another study, Disappear, limb salvage almost 90%, 96% at 6 months, primary patency 93%, 1 to 6 months. And they use bioabsorbable stents in Asian population. Absorb BTK, we heard about it earlier. Everolimus, the eluting stents, 38 limbs, and freedom from TLR 96, primary patency 96%. So in real world, BTK is more diffuse than focal stenosis. Now this is a study which I was part of as a PI as well, credenced BTK study, which major PI was Girish Varavdekar, our colleague. And the similar study, what Venkatesh presented, Esprit BTK, using bioabsorbable scaffolds in below the knee arteries. I think 30 patients we did it. These were some of the endpoints, and the results were quite encouraging towards the end of 3 years. Esprit 1 trial, everolimus again coated stents. No recoils, binary stenosis 12% at 1 year. Remedy BVS trial, there are different trials. Now this is, we are coming to the latest live BTK and Esprit BTK trial, again initiated by Raymond Warko, multicentric CLTI patients, category 4 and 5, and proximal 2/3 of the leg arteries were considered first. And these were essentially to evaluate the use of bioresorbable scaffolds, and then it was converted to Esprit BTK trial, where it's a drug which is everolimus, eluting resorbable scaffold versus angioplasty for infrapopliteal arteries, which was published in October 24 in NEJM, and was found to have use of scaffold superior to angioplasty in BTK arteries. When we look at the reinterventions in my study, 6 had reinterventions, and a combination, all had a combination of SFA stents and BTK drug-eluting stents. And there was thrombosis of SFA stents at various intervals, but what we found that the stents below the knee drug-eluting remained patent. Just an example here, you can see the extensive disease here. This was stented with drug-eluting stent. And he came back a few months down the line. This was, I think, just after the COVID. He came with a thrombosis, SFA stent. But when we look and go beyond that, we see that this stent, drug-eluting, has remained patent. At the second time intervention, runoff was good. And this is another patient, multiple diffuse disease in the SFA and tight stenosis in TP trunk with single vessel peroneal runoff. So we again put a drug-eluting sirolimus stent here in TP trunk, and then SFA was stenting here. And came back again for stent thrombosis in SFA region and progression of disease. But when we look at the distal angio here, this stent, drug-eluting stent, has remained patent, although this stent went down. So we had to do a re-intervention and ballooned it, the SFA. we had to stent that as well. And this segment, which was had a DES in TP trunk, state patent. Another example, again SFA disease. This was again distal popliteal going into TP trunk, and that was again put in a drug-eluting stent there and SFA stent. This was the picture, end picture, and then again few months down the line he came with SFA stent going down, but when we took a distal pictures, the patent drug-eluting stent which was planted earlier. So SFA we had to open, put another stent, and the status of drug-eluting stent remained good. And this was a variable period from probably 6 months to up to 1.5 years, and nice runoff. So in conclusion, stent in BTK arteries can be primary endovascular strategy in selected cases and pathologies. Drug-eluting stent is better results for primary patency. Everolimus better than paclitaxel coating stents. Is still off the label but used when indicated. Thank you.